Welcome to this video on oxygenation. We've done a ventilation and respiration video. If you haven't taken a look at that, please do. This is dealing with oxygenation, but we'll go over ventilation and respiration very briefly because they're very important in oxygenation itself. We need both adequate ventilation and adequate respiration in order to deliver oxygen and have oxygen do its thing. What are they? Just very quickly in a nutshell, again, there is a whole nother video dedicated to these topics, but ventilation is just the movement of gases, and this is just a mechanical movement. You're in the back of the truck and you're bagging a patient. Well, that's ventilation, as a mechanical movement of gases in and out of the bodily system. Next is respiration, and that's an exchange of those gases. So we're moving them physically, mechanically in and out, but now we need to exchange them at a cellular level. So that's respiration. Respiration is that cellular level exchange of gases. So as we get down into our alveoli, where there are capillaries, we're exchanging oxygen, we're exchanging carbon dioxide down at that cellular level. So oxygen is being unloaded onto red blood cells, onto those hemoglobins, and carbon dioxide is being offloaded in the lungs so we can breathe them out. Now, when dealing with oxygenation, again, both adequate ventilation and adequate respiration are needed for adequate oxygenation. But when we're dealing with oxygen and oxygenation, we're looking for measurement of oxygen within our system, and we're also looking potentially to add oxygen to the system. So once we measure it, is there an inadequate amount, and can we add some oxygen into our patient's system? Now let's talk about some measurement of oxygen within the system. Now, you might think this is pretty straightforward, and typically it is. On our trucks, we're looking at SpO2. This is a peripheral measurement of oxygen from the capillary bed, and we're typically measuring SpO2, typically reporting SpO2, but we can also measure SaO2 at the arterial level and SvO2 at the venous level. Now, SaO2 and SvO2 take a little bit more invasive measures to obtain, other than our simple SpO2 probe. On the arterial side, that SaO2, we'll need an ABG, an arterial blood gas, to get that. From our ABG, we can also get a PaO2, or a partial pressure of oxygen. That's going to be different than your SaO2. One's a saturation, a percentage. The other is a partial pressure, measured as a pressure, usually millimeters of mercury. But from our ABGs, we can get SaO2, which is the oxygen concentration in your arterial blood. And then on the venous side, we can get an SvO2, a venous saturation. So what is our oxygen concentration in our venous blood? So one is before offloading into the cells. The other is after our oxygen has been offloaded into the cells. So it's a kind of a before and after. So one, we need an ABG. On the venous side, we'll need a pulmonary line, a central line that goes a little bit further into the pulmonary artery to get an SvO2. Another way to think of these, SaO2 and SvO2, on the arterial side, that's our oxygen supply. And our SvO2 on our venous side, that is our oxygen demand. So we've got some sort of supply, some sort of oxygen coming in, and what are our cells demanding, and what are they using? So we can measure both what's coming into our system, and after our system has demanded and used up what they need, what is left over. Now, all that SaO2 and SvO2 comes in really handy when you have a patient who is starting to decompensate, and you need to figure out what is going on and what should you do. So I love this little flow chart, this little algorithm. So if we look on the bottom here, we've got 1, 2, 3, 4 options. I can give a fluid challenge. I can give fluid. I can give some sort of pressor, dobutamine, maybe dopamine. Maybe even go into levofed. I can give some sort of pressor right there, right? I can give whole blood. I can give some sort of blood transfusion, or I can just sedate my patient. Well, I've got 1, 2, 3, 4 options that are very, very, very dissimilar from one another. Dobutamine versus fentanyl. Analgesia are two very different paths to take. So which path are we going to take? Well, we can start with SvO2 and SaO2, right? So we can start with our supply and our demand. So anything SvO2 over 70% is pretty normal. So a normal healthy patient, I've got 100% oxygen coming in. My cells are going to use about 30% of that. Um, SvO2 is normal. Well, I'm going to do nothing. I'm okay there. My SvO2 is low. Well, I know I've got adequate demand coming in, assuming that my SaO2 is good, right? I've got adequate demand coming in, but I've got some sort of, or excuse me, not demand, supply. I've got adequate supply coming in, but I've got some sort of demand issue going on. So we can look at our SvO2 and our SaO2. So maybe I've got a low SvO2, so I've got higher demand versus my supply. So I can look at my supply here, my SaO2. My supply is low. Of course, my SvO2 is going to be low. If my SaO2 um, is 80%, of course my SvO2 is going to be 70, 60, 50%. So we're looking at both of these, SV and SaO2. So my SaO2 is low. Well, I'm going to get oxygen. That's pretty easy, right? I can increase my supply. Um, if my SaO2 is normal, so my supply is normal right here, I've got some increased demand, and we need to figure out why my demand is increased. So we can look at cardiac output in our normal, everyday ambulances. We don't have cardiac output monitors, but perhaps you've got some information on cardiac output. We can look at cardiac output. Is it high? Is it low? Is it kind of, this is kind of dichotomous. So is it on the higher side? Is it on the lower side? We can look at hemoglobins. Are they normal? We can look at our that PAOP, pulmonary artery occlusion pressure, maybe a wedge pressure if you've heard that, your wedge pressures. So looking at that, and that can kind of guide our treatment modalities. But we're starting with SvO2. What's my demand look like? And my SaO2, what's my supply look like? So we're thinking SaO2, our arterial oxygen, and SvO2, our venous oxygen. What does my supply look like coming into my system? And what does my demand look like in that same system? All right, so we've got our supply, we've got our demand. Well, now we need to deliver it, right? So I've got my supply, I need to deliver my supply given a demand. And delivering that, we need hemoglobin, those little oxygen carrying molecules, right? So each hemoglobin carrying up to 4 oxygen molecules. We've got our hematocrit, which is a fraction of red blood cells within our total blood volume. And then we can kind of graph out this oxygen hemoglobin dissociation curve. So how easily are those oxygens that are bound to our hemoglobins offloading into our cells for use? So we've got our supply, but how easily is that supply being offloaded? If you're looking at your patient's lab values, you're picking them up, doing an interfacility transport, or just looking through your patient's medical history, hemoglobin, so number of oxygen carrying cells. We're looking at an average, kind of a typical value of about 15 grams per deciliter of blood. For our hematocrit, that's the fraction of red blood cells in your blood volume. We're looking at about 45% of your blood volume should be red blood cells. And we mentioned this oxygen hemoglobin dissociation curve. Well, here it is for you, and what this just illustrates is I've got some supply of oxygen, and that's on our horizontal axis here. That's partial pressure of oxygen, which we can get off our ABGs, our arterial blood gases, and then so we've got our supply. Well, given our demand, how easily are they offloading into our cells for use? So that red line there, this is just our normal curve. So if I've got a partial pressure, um, yeah, let's say of 60, right? So I can follow this up, and well, this is going to give me a SpO2, so the saturation of just under 90% looks like, right? So I've got a supply right here, and I'm offloading this demand just under 90%. Well, this is going to change a little bit. So you've got this green dotted line, this blue dotted line. So we've got a left shift, we got right shift, and this really has to do, there are a number of factors that change this, that affect this, but the big ones for our purposes are acidosis and alkalosis, or acid-base status. So this right shift, as our patient gets more acidotic, let's say a DKA patient, diabetic ketoacidosis, I've got a partial pressure right there of 60. You can follow that up, and instead of just under 90% saturation, now I'm hitting this blue dotted line right there, and we can follow that over, and we get 60, maybe a little above 80%. So we're going from like 89% to 82% just because of that acidotic state. Same thing with that left shift. So this alkalotic shift, so a decreased hydrogen ion. So we're decreasing our acid. We're decreasing our CO2. So I've got this alkalotic state, right? So imagine some alkalotic state, and right there at a partial pressure of 60, we can follow that up. We go through our, what was it, 82%, through our 89-ish percent up here, and now we're above 90, right? So if we follow it over, now we're maybe at 92, 94%. So this this dissociation curve just tells us at a given pH, at a different kind of acid-base status, acid-base level, how easily are our oxygens offloading from our hemoglobins and into or onto our cells for use. And how easily this happens, we talk about the Bohr effect and the Haldane effect. Bohr effect has to do with oxygen. The Haldane effect has to do with carbon dioxide. We're not going to get into it here. You can click on that ventilation video for a more in-depth look at these two effects. But just know that the Bohr effect and the Haldane effect both play into that oxygen hemoglobin dissociation curve. And in a normal state, a normal patient, about 20, maybe 30% of the oxygen delivered, that supply delivered to our tissues, to our cells, is used. So remember that SvO2, anything over 70, we are happy with. Anything under 70, there's something going on. But in a normal state, about 20 to 30% of the supply delivered to our tissues is used, a large part of that oxygen delivered to our tissues is not used. So, um, we can use that information to catch states of shock. So as we get above those delivery states, so above those 20-30%, in shock, yeah, our tissue, our oxygen extraction is going to go 20, 30, 40, 50, 60%. So we're going to see our SVO2s drop dramatically in shocky states. And if we have the means to do so, if we've got that central line in place and that pulmonary artery catheter in place, and we're measuring SVO2, we can really catch our patients decompensating into shock, delving into shock very quickly, and sooner than our other vital signs. All right, so really, what does this all mean for us out in the field? Well, this all goes into our ventilatory management. How are we managing our patient? How are we ventilating them? And we can do, if we boil it down, we can do four things. We can play with our respiratory rate. We can play with tidal volumes, our respiratory volume. How much are we, how much volume are we giving per breath? We can play with our FiO2. What's the percentage of oxygen that we're giving? So we can crank the oxygen or we can tone it back, and then we can play with PEEP, peak end expiratory pressure. So if we're just bagging, how hard are we bagging? If we've got a maybe CPAP, can we put them on CPAP? Can we play with that PEEP? Do we have a vent? Can we play with all four all at once? Or are we doing manually? So all this boils down to these four things, and if I want to increase oxygenation, if I want to play with oxygenation, what am I going to do? So let's say I want to increase oxygenation in my patient because, honestly, I can't think of any scenario in which I would want to decrease oxygenation in my patient. So let's say we're going to increase oxygenation. I've got an SpO2 of 80%, and I determine that that's a little too low. I don't like that, and I want to increase the oxygen in my patient's system. So we've got our four parameters, and we're going to cut out respiratory rate and we're going to cut out tidal volume because those two things are not going to increase oxygenation. They're going to affect carbon dioxide levels. So if I bag my patient faster, I'm going to decrease my patient's carbon dioxide level in the system. If I increase the tidal volume, I'm going to decrease my patient's carbon dioxide level, and the inverse as well. If I decrease respiratory rate or I decrease tidal volume, I'm going to increase carbon dioxide levels. But respiratory rate, tidal volume, respiratory volume do nothing for oxygenation. And that just needs to be repeated over and over again, especially to your EMTs, especially to your new firefighters who think they're going to increase in SpO2 by bagging faster. Respiratory rate and tidal volume, increasing both of those or either of those will not affect oxygenation. All they will affect is carbon dioxide. So what we're going to focus on is FiO2, what's the percentage of oxygen that I'm giving my patient, and PEEP, my peak and expiratory pressure. Increasing my FiO2, my fraction of inspired oxygen, is pretty simple, pretty straightforward. We're just going to give them oxygen. So we can move from room air to a nasal cannula. If that's not doing the job, we can move from a nasal cannula to a non-rebreather, and we can just crank that oxygen. If they're on a ventilator or even CPAP that has or BiPAP that has a little more functionality, we can increase FiO2 anywhere from 21% to 100%. So just crank that oxygen, and that's how you increase FiO2. With PEEP, if we're increasing PEEP, peak and expiratory pressure. We are keeping our alveoli open. We are recruiting previously closed, collapsed alveoli, so we're increasing potentially respiration along with ventilation. So extra gas exchange. So if we increase PEEP, we are going to increase our oxygenation. With PEEP, you do have to be careful with certain patients because it is going to increase intrathoracic pressure, is going to increase pressure on the heart and going to decrease cardiac output. So be careful with PEEP, but we're going to increase PEEP, we're going to increase FiO2 if we need to or want to increase oxygenation. So in summary, there is a difference between ventilation and respiration. Ventilation is mechanical, in and out. Respiration is a cellular level exchange of gases. We talked about oxygen measurement. There's SpO2, which we're pretty familiar with, and then there's SaO2, arterial. There's SvO2, venous. So we're talking about a supply and a demand, and we can compare the two and see if there's an issue on one end or the other. And then oxygen delivery, if we want to increase oxygenation in our patient. We're not so concerned about respiratory rate, not so concerned about tidal volume, but we are concerned about FiO2, that fraction of inspired oxygen, that percentage of oxygen being delivered. And we are concerned about PEEP, that peak and expiratory pressure. And as always, if you have any questions, comments, concerns, and even cuss words, please feel free to let us know.